Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Aboussekhra, your host for today's episode, and I'm joined by Lyan Tawfik.
Hi, everyone. I'm so happy to be here. Let's jump right into today's discussion.
All right, Lyan. So, today's topic is degenerative diseases. So, what should we think of when we hear the phrase neurodegenerative diseases?
Okay, so basically, it's a progressive loss of neurons that's significant enough to cause a disease. It's usually associated with the accumulation of abnormal protein aggregates over time, which can either be outside the cell as deposits or inside the cell as inclusions. And these aggregates are what damage the neurons eventually.
Oh, so it's a loss of neurons, and depending on the specific part of the brain or the group of cells that get affected, that will determine the symptoms that you have, right?
Exactly. So, for example, if it is affecting the cerebral cortex, it will lead to cognitive changes. So, think of things like memory loss as in dementia of Alzheimer's.
Wait, but would cognitive deficits or dementia only be associated with Alzheimer's?
Actually, no. These cognitive deficits can also be in other types of dementia, like vascular dementia, where it's caused by interrupted vascular supply, or frontotemporal dementia, where abnormal proteins cause frontal or temporal lobe degeneration. We'll come back to that later.
Okay, back to our main discussion. Where were we again?
Okay, we said we characterize degenerative diseases by the area affected. So if it's the cerebral cortex, think of cognitive changes like dementia. Now, if the cerebellum or its pathways are affected, think of ataxia, which is the lack of coordination or balance. And if the motor systems, like the motor tracts, are affected, think of weakness and muscle dysfunction, like swallowing or breathing difficulties, such as in ALS and late Huntington's. Finally, if the basal ganglia is affected, think of movement changes.
Honestly, I always forget what exactly it is that the basal ganglia does, or what it's made up of. So, before we continue, here's a quick recap and some random mnemonics, and hopefully, this makes it a bit easier. So, the basal ganglia is a group of subcortical nuclei, meaning a group of nerve cell bodies situated deep inside the brain. Its function is to stop unwanted movements, so less tremors, for example, and it also allows voluntary movements. So you can think of it like a police checkpoint that either allows or stops movement, making sure only the appropriate ones pass. The three subcortical nuclei of the basal ganglia that you should know for now are the lentiform nucleus, the substantia nigra, and the striatum. So for basal ganglia, remember less as LSS, because less tremors, and LSS as in L for lentiform, S for substantia nigra, and another S for striatum.
Yes, so the nuclei of the basal ganglia are LSS, lentiform, substantia nigra, and striatum.
And for each one, it has parts. For the lentiform, it includes the globus pallidus interna and externa. So think of it as lane-tiform, since buses can have their own lane on the street now. So with lane-tiform, think of globus pallidus interna and externa.
Okay, so lentiform is composed of the globus pallidus interna and externa.
Yeah, so that was lentiform. Now for the striatum. It includes putamen and caudate. Again, another weird mnemonic, so bear with me, but putamen sounds like vitamin, and caudate sounds like cow date. You can think of foods we eat like cow meat and dates, and just say I ate 'em in striatum. So striatum, as in I ate the cow and date, caudate, and got the vitamin putamen.
So basically, the lentiform is made up of the globus pallidus, think of lane and bus. And striatum is composed of the caudate and putamen, think of I ate the cow and date and vitamin. Now, in terms of how it works exactly, the basal ganglia has feedback loops, direct and indirect pathways that regulate movement. The direct pathway allows movement to happen, while the indirect inhibits movement. So, starting with the direct pathway, the motor cortex starts by sending an excitatory signal using glutamine to the striatum. Which structure made up the striatum again?
The caudate and putamen.
Yes. Then the striatum inhibits the globus pallidus interna using GABA. So normally the globus pallidus sent inhibitory signals to the thalamus to stop movement, but in this case we inhibited the globus pallidus.
Okay, so now the thalamus is free to work and send signals to the motor cortex, which leads to movement.
Exactly. So it goes from motor cortex to the striatum to globus pallidus interna to the thalamus and back again to the motor cortex for movement to occur. And all of this is being enhanced by which hormone?
Dopamine.
You got it. Dopamine coming from the substantia nigra stimulates the D1 receptors in the striatum to increase globus pallidus inhibition, and thus the thalamus gets activated and causes movement. Now let's look at the indirect pathway, which does the opposite. So we'll start with a simple overview. First, the motor cortex excites the striatum. Then the striatum inhibits the globus pallidus externa. And now that the globus pallidus is inhibited, it cannot inhibit the subthalamic nucleus, so this allows the subthalamic nucleus to be active and free. Now the activated subthalamic nucleus will excite globus pallidus interna as it's meant to do. And once the globus pallidus interna is active, it inhibits the thalamus.
Okay, I'm sure that was a lot, so I like to think of it this way. Imagine we have a group of people trying to free a bunch of thieves, and the thieves are not really so loyal to each other. So, first, we have the striatum. They come to help the thieves out to stop or inhibit the police, as in globus pallidus police, or the globus pallidus externa. Now, since the police is not working, they can't capture or inhibit the subthalamic thieves. Now, the subthalamic thieves aren't inhibited by the globus pallidus externa, so they're happy and active and roaming freely. But these thieves are traitors. They go to the other internal police this time, the globus pallidus interna, and wake them and alert them or basically activate them, meaning they expose the other thieves, the thalamus thieves. So basically, now the internal police globus pallidus interna is activated or alerted, and they will go capture or inhibit the thieves, the thalamus thieves. So it's a pretty sad ending for them in jail, and we know that no thalamus means no movement. So the indirect pathway inhibits the thalamus and therefore stops movement.
I hope we didn't lose you there. So just to make sure we really nailed it into everyone's mind, we'll repeat it one last time. First, the motor cortex excites the striatum, same as in the direct pathway. And then the striatum will release GABA again to inhibit the globus pallidus externa. So now the globus pallidus externa is inhibited and cannot release GABA to inhibit the subthalamic nucleus. So this allows the subthalamic nucleus to be free to release glutamate and excite globus pallidus interna as it's meant to do. And finally, once the globus pallidus interna is active, it inhibits the thalamus, so it inhibits movement. And now, since the indirect pathway stops movement, what do you think dopamine will do in the indirect pathway?
We said dopamine means more movement, so it would inhibit the indirect pathway, right?
Exactly. Since dopamine allows movement, in this case, it would inhibit this whole indirect pathway. It acts on D2 receptors, unlike the direct, where it acted on D1. Anyway, for now, just know that if the basal ganglia is affected, think of movement changes. Alright, now you can have hypokinetic and hyperkinetic diseases. What type do you think is Parkinson's? Hypokinetic or hyper?
Hypokinetic because of the slow shuffling and all?
Yes, exactly. Parkinson's is hypokinetic, and Huntington's is hyperkinetic, since it has all these involuntary sudden movements, at least initially.
Okay, so as a summary, we said if cerebral cortex is affected, think of cognitive changes like dementia. And if cerebellum or its pathways are affected, think of ataxia, which is lack of coordination or balance. And if the motor systems, like the motor tracts, are affected, think of weakness and muscle dysfunction, like swallowing or breathing difficulty, such as in ALS and late Huntington's. And if the basal ganglia is affected, think of movement changes. Okay, I think now it's about time to go through each disease. Let's start with Parkinsonism.
Okay, with Parkinsonism, we're talking about a neurodegenerative disorder characterized by four main symptoms: tremors, rigidity, bradykinesia, or slow of movements, and postural instability. And all these symptoms happen because of damage to dopaminergic neurons that project from the substantia nigra to the striatum. This pathway is super important for controlling movement.
Wait, Lyan, by Parkinsonism, you mean Parkinson's disease?
Not necessarily. When we say Parkinson's disease, this means we excluded all other causes, like drug-induced or post-encephalitis, because in Parkinson's disease, we don't know the cause.
Oh, right, okay, got it. So if those neurons are damaged, does that mean there's less dopamine?
Yes, exactly, Ala. And that's a huge problem because dopamine plays a key role in regulating movement. And that explains why you end up with decreased movement initiation and increased inhibition of movement, leading to bradykinesia and rigidity. Remember TRAP, TRAP. T for tremor, R for rigidity, A for akinesia, and P for postural instability.
Okay, hence we call Parkinson's a hypokinetic disorder.
Yes, and it can even lead to dementia as well. Also, the damage to the substantia nigra isn't just functional, it's also structural. In a healthy brain, the substantia nigra looks dark because of the melanin in dopaminergic neurons. But in Parkinson's, those dopaminergic neurons die off. So when you look at the substantia nigra, it literally appears depigmented or washed out.
So grossly, the substantia nigra looks washed out. Now, let's look at the histopath. What are the changes that would happen there?
Microscopically, you will see misfolded proteins, specifically alpha synuclein. Remember that because it's important. This alpha synuclein will form globules called Lewy bodies inside neurons.
Okay, so we have intracytoplasmic inclusions containing a protein called alpha synuclein, and we call these inclusions Lewy bodies. That sounds familiar. Is this connected to Lewy body dementia as well?
That's a great question. It's actually a key feature of both, but the difference just lies in where they accumulate. So in Parkinson's, where did we say it accumulates?
Substantia nigra.
Yup, but for Lewy body dementia, it's more widespread, and it affects the cerebral cortex early on, and that's why it causes cognitive impairment first.
All right, and for treatment, since it's mainly dopamine loss, we can just give L-DOPA, right?
Initially, yes, we can give L-DOPA and patients would respond at first, but this does not stop the disease progression. It only manages the movement symptoms. And speaking of progression, Parkinson's symptoms tend to get worse over time, eventually leading to severe motor slowing, postural instability, and even near immobility. Unfortunately, that can make patients more vulnerable to things like aspiration pneumonia or falls, which are the leading causes of death in advanced Parkinson's.
Yeah, we should keep in mind that it progresses over years, causing immobility and dementia. Is there no other treatment then?
Another treatment is also deep brain stimulation, where you implant electrodes that mimic the function of the basal ganglia. They're implanted in the globus pallidus and subthalamic nucleus.
All right, that's a wrap on Parkinson's. Now we've covered hypokinetic disorders, but before we switch gears and talk about hyperkinetic disorders like Huntington's disease, let's quickly go over what dementia is.
Of course, dementia is an umbrella term, where you have cognitive impairment and have memory loss that is severe enough to impair everyday activities. Causes of dementia include first, Alzheimer's disease most commonly, then we have vascular dementia, which is dementia due to strokes or reduced blood flow to the brain. Then there's also Parkinson's disease and Lewy body dementia. And finally, it can also be caused by frontotemporal lobar degeneration, where you have atrophy of the cerebral cortex, predominantly frontal and temporal lobes.
All right, so causes of dementia could be Alzheimer's, vascular dementia, Parkinson's disease, Lewy body dementia, or frontotemporal lobar degeneration.
That's right.
So that's it for dementia. Now let's talk about Huntington's.
So, Huntington's is a hyperkinetic disorder, meaning it has excessive involuntary movements. What's the reason behind it? It's due to the degeneration of the striatum of the basal ganglia. Again, what was that made up of?
We said striatum, I ate the cow and date and vitamin, so caudate and putamen.
Exactly. So, again, we have degeneration of the striatum, and this loss of neurons disrupt normal movement control, leading to the hallmark symptoms, chorea, which are jerky, uncontrollable movements of the limbs, head, or face.
That makes sense, but we should mention that Huntington's isn't just a movement disorder. It's also important to note that there are also cognitive and psychiatric symptoms too.
Absolutely. Patients can experience forgetfulness, behavioral changes, and depression, and unfortunately, the suicide rate is high in Huntington patients. These cognitive symptoms tend to develop alongside or even before the movement symptoms. And Huntington's is a progressive neurodegenerative disorder that usually starts around the age of 40, but the exact age of onset depends on genetics.
Speaking of genetics, I know Huntington's is an inherited disorder. So, what exactly causes it?
Great question. Huntington's is caused by a mutation in the HTT Huntington gene, or chromosome 4. This mutation leads to an increase in CAG trinucleotide repeats, which code for glutamine. And actually, the more CAG repeats, the earlier the disease starts. This is a phenomenon called anticipation, where the disease tends to appear earlier in each generation due to the expansion of repeats, especially in paternal inheritance.
So it becomes more severe over generations. Now, we said that the mutant Huntington protein is building up. But what exactly does it do to neurons?
The mutated protein misfolds and forms aggregates, which accumulate inside the nucleus of neurons. So be careful, in Huntington's, it's intranuclear, not intracytoplasmic inclusions. And these intranuclear inclusions interfere with transcription and normal cellular processes like axonal transport, which ultimately kills the neurons. And we know the striatum plays a key role in movement regulation. So since the striatum is affected, this will lead to excess movement, which is chorea.
Alright, so now we know that the striatum is degenerating, but why does it cause excess movement? Is this affecting the direct or indirect pathways?
Well, it depends. In early Huntington's, the indirect pathway is disrupted first, which leads to more movement, because when we stop the indirect or inhibitory pathway, we get excess cortical activity and excess movements. That's why chorea happens. However, as the disease progresses, the direct pathway also gets affected, leading to decreased excitatory thalamic output to the cortex, so the patients shift from hyperkinetic to hypokinetic or akinetic symptoms, which resemble the late stage of Parkinson's.
And what about if we were to look at the brain? What changes would we see?
The brain in Huntington's will show atrophy of the caudate nucleus and putamen. This causes enlarged ventricles due to loss of brain tissue. So if you ever see enlarged ventricles with caudate atrophy on imaging, that's Huntington's. And on a microscopic level, there's neuron loss, gliosis, which is like a scar formation, and intranuclear inclusions containing the mutant Huntington protein.
So we have atrophy of the striatum leading to enlarged ventricles and intranuclear inclusions. Now, let's look at the diagnosis.
Okay, it's mainly a clinical diagnosis when it comes to Huntington's, so it's based on symptoms and family history. We can also do genetic testing for CAG repeats to confirm it. Another way is imaging, like an MRI or CT, as they can show caudate atrophy, but it's not always necessary for diagnosis.
And this is also a progressive disease like Parkinson's. But how long does it usually take to worsen?
Huntington's is slowly progressive, with death typically occurring around 15 years after symptoms start. And unfortunately, there's no cure, but some treatments can help manage symptoms.
So, to summarize, Huntington's is a hyperkinetic disorder due to striatum degeneration, mainly caused by CAG repeat expansions in the Huntington gene. It leads to chorea, cognitive decline, and psychiatric symptoms, with no cure but some symptom management options. Sounds about right?
Exactly. And remember, caudate atrophy and CAG repeats are the big buzzwords for Huntington's.
Okay, next up, let's talk about Alzheimer's.
Let's do it. Alzheimer's disease is a progressive neurodegenerative disorder that primarily affects memory, cognition, and behavior. It's most common in people older than 84 years. Remember, as we mentioned earlier, Alzheimer's is one of the most common causes of dementia in older adults.
Yeah, and here the main part of the brain that gets affected is the hippocampus.
Yes, the hippocampus is one of the earliest and most affected regions, since it's a key part of the limbic system, which regulates memory, learning, emotions, and spatial navigation. The damage here explains the early memory impairment seen in Alzheimer's.
Okay, now what about the pathogenesis? What exactly causes this damage at the molecular level?
The disease is caused by abnormal protein accumulation, specifically amyloid plaques extracellularly and neurofibrillary tangles intracellularly. These disrupt normal neuronal function and lead to neurodegeneration.
Yeah, and if you're wondering what are amyloid plaques, normally neurons have a membrane protein called amyloid precursor protein, or APP. This protein is usually cleaved or broken down by alpha secretase and gamma secretase into soluble fragments that get recycled. But in Alzheimer's, there's an abnormal cleavage. Instead of alpha or gamma secretase, we will have beta secretase cutting the APP, producing amyloid beta, which is insoluble and sticky.
Exactly. So remember, beta secretase produces amyloid beta, and these amyloid beta fragments accumulate outside neurons, forming amyloid plaques that disrupt communication and cause inflammation due to microglia getting activated. These plaques interfere with synapse function, so they break neural connections and contribute to memory loss.
Yes, okay, so extracellular aggregates or plaques of amyloid beta peptides. Now, what about neurofibrillary tangles?
Alright, so for some reason, we don't really know why yet, but when these amyloid beta plaques get taken up by the cell, that will cause kinases to phosphorylate tau protein. So we end up with intracellular aggregates made up of hyperphosphorylated tau protein. So again, in case I lost you there, think of it like this. We have amyloid precursor proteins that get cleaved by the wrong enzyme, so they become plaques that deposit outside the cell. And when the cell takes up this amyloid plaque, certain enzymes or kinases will phosphorylate tau, making us end up with hyperphosphorylated tau protein.
Okay, so intracellularly, we have hyperphosphorylated tau, and extracellularly, we have amyloid plaques. But wait, we didn't really cover what tau is.
Ah, yeah. Thank you for bringing that up. Normally, tau stabilizes microtubules, which help in transporting nutrients and for signals inside neurons. But when tau becomes hyperphosphorylated, it can't stabilize microtubules. So we have disruption of microtubules leading to neuronal transport failure and cell death.
And this hyperphosphorylated tau is what we call neurofibrillary tangles.
Yep.
Now, let's look at how Alzheimer's affects the structure of the brain. What are the gross and microscopic features?
Well, grossly, the brain shrinks due to neuronal loss. You'll see cortical atrophy, especially in the hippocampus, enlarged ventricles, we call that ventriculomegaly, and narrow gyri, and widened sulci, giving the brain a shrunken appearance. So think shrunken brain and larger ventricles. And microscopically, there are two hallmark findings, which we already mentioned, so you tell me. Let's see if you were listening.
Okay, so neuritic plaques extracellularly composed of amyloid beta, and neurofibrillary tangles inside the neurons, which are aggregates of hyperphosphorylated tau.
Exactly. And I'll just add one thing. Surrounding these neuritic amyloid beta plaques, you'll have dystrophic neutrites, which are like abnormal axons and dendrites.
Okay, now let's move on to clinical presentation. So, how do Alzheimer's patients usually present?
The first symptom is typically short term memory loss, which progressively worsens. Over time, they develop cognitive decline, so difficulty with reasoning, problem solving, and language, disorientation, like getting lost, forgetting dates and places, and finally, behavioral changes, like apathy, aggression, agitation, or mood swings. Then, in cases of severe progression, you'll see loss of mobility, muteness, and complete dependency on caregivers. So, in the final stages, patients are often bedridden, and unfortunately, most die from complications like pneumonia due to immobility.
I see. So, cognitive decline and behavioral changes. And if it's severe, you'll see loss of mobility as well. And what about diagnosis?
Actually, diagnosis is mainly clinical, but supportive tests would include imaging and certain markers in the CSF. So you can use MRI findings where you'll see brain atrophy, mainly of medial temporal lobe, like in the hippocampus. You'll see enlarged ventricles and narrow gyri and widened sulci. And for the CSF markers, you'll see high tau concentrations. Also, some cases are genetic. We call it familial Alzheimer's disease, or FAD. Genetically, mutations in amyloid precursor protein gene, or APP gene, or in the component of gamma secretase presenilin 1 and presenilin 2 genes, are linked to early onset familiar Alzheimer's.
Well, that was a lot. So basically, familial Alzheimer disease is either in the APP gene or the presenilin genes.
Yup, and fun fact, this APP gene is on chromosome 21. So in people with trisomy 21, which is also known as Down syndrome, they have an extra copy of chromosome 21, right? This means that they have an extra APP gene, so they're at a much higher risk of developing early onset AD.
Okay, and moving on to treatment, I know there's no cure, right?
Yeah, unfortunately, since there's no curative treatment for Alzheimer's, we can only manage symptoms progression and improve quality of life, not stop the disease. And the treatments include cholinesterase inhibitors and memantine. Cholinesterase inhibitors, like donepezil, rivastigmine, increase acetylcholine levels which support memory and cognition. And memantine reduces excessive glutamate activity, which is neurotoxic, so it prevents more neuronal damage. But even with this treatment, unfortunately, survival is only for about 3 to 10 years after diagnosis.
Okay, so cholinesterase inhibitors and memantine to manage symptoms. Alright, now let's move on to the last disease, shall we?
Yes, for our final segment, let's talk about amyotrophic lateral sclerosis, or ALS. You know, another fun fact, this disease was also called Lou Gehrig. It was named after a famous baseball player who was diagnosed with it in the 30s.
Oh, yeah, I think it's also the disease that Stephen Hawking was diagnosed with.
Yes, that too. So, first off, let's look at what ALS is. ALS is a neurodegenerative disease that affects both upper and lower motor neurons, leading to progressive muscle weakness and eventually paralysis. If you break down the term amyotrophic lateral sclerosis, we say sclerosis because in ALS, the degeneration of upper motor neurons leads to scarring or sclerosis of the motor nerves in the lateral corticospinal tracts of the spinal cord. So, amyotrophic, A means no. Myo refers to muscle, and trophic means nourishment, meaning there's no muscle nourishment leading to muscle atrophy. Lateral refers to the lateral portions of the spinal cord, where motor neuron tracts are located. And sclerosis, because as these nerve fibers degenerate, they are replaced by hardened scar like tissue.
Sounds pretty straightforward to me. So, essentially, ALS is named for the progressive loss of motor neurons, resulting in muscle wasting, as in amyotrophy, and scarring or sclerosis along the lateral spinal tracts. That kind of also explains the pathogenesis.
Yeah, in terms of pathogenesis, as we mentioned, it's caused by degeneration of motor neurons, both upper or lower, leading to loss of upper motor neurons, where you'll see spasticity, hyperreflexia, and Babinski sign, and loss of lower motor neurons, which leads to muscle weakness, atrophy, and fasciculations. There's also loss of lower motor neurons in the brainstem, in what we call the bulbar region, and this will lead to the bulbar symptoms, which are dysphagia, difficulty swallowing, and dysarthria, which is slurred speech.
Okay, so upper motor neuron damage indicated by spasticity, hyperreflexia, and Babinski, and lower motor neuron damage indicated by weakness, atrophy, and fasciculation. And Babinski is that thing where you stroke the sole of the foot, and if the toes fan out and move upward, it indicates a positive finding of upper motor neuron damage, right?
Yeah, and it's an abnormal finding in adults and older children. Now, for ALS, the biochemical mechanism is caused by abnormalities in 3 genes, causing certain proteins to misfold and aggregate. And the genes are SOD1, superoxide dismutase 1, TDP43, TAR DNA binding protein, and C9ORF72, chromosome 9 open reading frame 72. Can you guess which gene is the most commonly affected?
Is it the C9OR something something?
Yeah, that one. Of course, the most annoying one to memorize has to be the most common. But yeah, the answer is indeed C9ORF72. I'll just quiz you about it till you memorize it. So the C9ORF72 gene, hexanucleotide repeat expansion, is the most common genetic cause of familial ALS. If you're wondering what does that mean, first of all, an open reading frame, ORF, is a continuous stretch of DNA that contains the instructions for making a protein. So in C9ORF72, this open reading frame normally codes for a protein. However, in ALS, a hexanucleotide repeat expansion occurs within the gene. It means that this gene normally has a sequence like GGGCC in our DNA with 6 letters, but in ALS, the sequence repeats too many times, so that's hexanucleotide repeat expansion, which disrupts normal protein production and leads to abnormal protein building up.
Okay, so basically, the genes mutate and cause misfolded proteins to form, which will cause aggregates or inclusion bodies in the cytoplasm of motor neurons.
Yes, exactly. And with ALS, it's really important to look out for the life threatening symptoms, like respiratory impairment and dysphagia. So you'll always be doing pulmonary function tests and screening to evaluate the swallowing of the patient.
Okay, now for morphology. What does ALS look like in the brain?
Grossly, the spinal cord shows thinning of anterior nerve roots due to motor neuron loss, and we see atrophy of skeletal muscles. And microscopically, ALS is marked by loss of motor neurons in the anterior horn of the spinal cord and corticospinal tract degeneration, which carries the motor signals.
Got it. So we'll see muscle atrophy, thinning of the anterior nerve roots, and loss of motor neurons in the anterior horn of the spinal cord, along with degeneration of the corticospinal tract. And how would patients present? What are the clinical features?
We technically already mentioned them when we discussed the pathogenesis, so I'll ask you about them. So, ALS symptoms are progressive and usually start with asymmetric limb weakness. Over time, they develop upper motor neuron signs, which were,
Spasticity, hyperreflexia, and Babinski sign.
uh huh, and they also develop lower motor neuron signs. Can you also give me examples?
Weakness, atrophy, fasciculations,
Yes, and finally, they also have bulbar symptoms, like,
difficulty swallowing and speaking, so dysphagia and dysarthria.
and what was the most common gene affected?
C9, open reading frame 72.
Yes, C9ORF72. Perfect, you got them all. One point to add is they also develop abnormal behavior like mood incongruent behaviors, so something like laughing and crying simultaneously. And for this prognosis, unfortunately, most patients die from respiratory failure due to diaphragm paralysis within 3 to 5 years of diagnosis.
Yeah, so unfortunately, not the best prognosis. Finally, for treatment, again, there's no cure, unfortunately.
Yeah, exactly. There isn't a cure. However, Riluzole can modestly slow progression by reducing glutamate excitotoxicity. It blocks voltage gated sodium channels on neurons and inhibit glutamate release. Other treatments focus on symptom management and improving quality of life.
Riluzole, got it.
Alright, so we're basically done. Time for some quick fire questions. I want you to answer super fast. Are you ready?
Let's do it.
Okay. Amyloid beta plaques and neurofibrillary tangles. What do you think of?
Alzheimer's.
Do they have aggregates that form intracellularly or extracellularly?
I see, you're trying to trick me. The amyloid plaques form extracellularly, and neurofibrillary tangles form intracellularly.
Ah, you got me. But good job. Where do you see Lewy body inclusions formed by alpha synuclein?
This is Parkinson's, and it's intracytoplasmic.
Yes. And where do you see degeneration of the substantia nigra and depletion of dopamine?
Parkinson's again.
What structure is affected in Huntington's?
Striatum.
Okay. And how would you compare the early and late stage of Huntington's?
Okay, in early stage, only indirect pathway affected. So we have hyperkinetic choreotic movements. But in the later stages, both pathways are affected overall. So it becomes hypokinetic/akinetic instead.
Okay. And give me the upper motor neuron and bulbar symptoms of ALS.
Okay, so for upper motor neuron, it's hyperreflexia and spasticity and Babinski sign. For bulbar, it's dysphagia and dysarthria.
Okay. And finally, what are the three abnormal protein coding genes in familial ALS?
Okay, so we have SOD1 and TDP43 and C9ORF72.
Nice. Good job. Let's wrap up with this case scenario for you guys to make sure that you're all caught up. Then we'll summarize everything briefly. A 68-year-old man presents with progressive muscle weakness over the past 6 months. He notices difficulty in lifting his arms and legs, and he's been tripping more often. His family also reports he has difficulty swallowing and speaking. On examination, you observe muscle wasting, fasciculations in his limbs, and hyperreflexia with a positive Babinski sign. There is also tongue atrophy and slurred speech. His reflexes are brisk, and there's noticeable spasticity. And he sometimes laughs and cries at the same time. What's the most likely diagnosis? Time's up, and the answer is ALS.
Okay, so I hope you guys got it. And I have good news, we're all done. Now, to summarize, first, we talked about Parkinson's disease and how it's caused by abnormal accumulation of alpha synuclein, which leads to degeneration of dopaminergic neurons in the substantia nigra, resulting in resting pill rolling tremor, rigidity, bradykinesia, and postural instability. Then, we covered Huntington's disease, which is caused by CAG trinucleotide repeat expansions in the HTT gene, leading to toxic Huntington protein accumulation and degeneration of the caudate and putamen, which causes chorea, psychiatric symptoms, and cognitive decline. Then, Alzheimer's disease. We mentioned it's characterized by amyloid beta plaques and neurofibrillary tangles, which are hyperphosphorylated tau, leading to progressive memory loss, cognitive decline, behavioral changes due to hippocampal and cortical atrophy. And finally, ALS. It results from the degeneration of upper motor neurons in the motor cortex and lower motor neurons in the spinal cord, causing muscle atrophy, weakness, fasciculations, spasticity, and difficulty swallowing and speaking. Remember the bulbar symptoms. And the most common genetic cause is C9orf72, hexanucleotide repeat expansion.
Exactly, and they are all devastating neurodegenerative diseases, but they affect different parts of the nervous system and thus present in very different ways.
And that's it for today's episode on neurodegenerative diseases. Thank you, Lyan, and everyone for joining us, and we hope this helped simplify a tricky topic. Don't forget to follow so you don't miss future episodes, and you can now leave a review in the description below to help us improve with every episode. We'll catch you next time on PodBites.